Thank you so very much for the kind introduction and for the opportunity to speak today. I'm going to focus my discussion on an example of a chronic debilitating condition that occurs in both men and women, but seems to have different etiologies and more significant impact on women, and that's osteoarthritis. Osteoarthritis is the leading cause of, or a leading cause of functional disability and reduced quality of life among adults. So if we look at osteoarthritis prevalence, if we look at the graph at the top left, the incidence of osteoarthritis is expected to continue to increase, with women representing the majority of those with osteoarthritis. If you look at the graph at the bottom left, at every age group over the age of 25, women are more likely than men to have osteoarthritis. The overall incidence of osteoarthritis in the population is about 25%, and it's estimated to be about 30% for women and 20% for men overall. When we look at self-reported joint pain with the graph on the right, you can see that the self-reported joint pain is more common among women than among men at all joints except the shoulder and elbow. But you especially see the differences at the knee. And osteoarthritis of the knee accounts for more than 80% of the total disease burden of osteoarthritis among all patients. And so again, going to focus on the issues of osteoarthritis, specifically of the knee, considering its prevalence and impact. This is not just an issue in the United States. If you look at global OA osteoarthritis, global knee osteoarthritis prevalence, in all countries, it increases with age. It varies, however, among countries, but if you look at sex and gender differences, there's an increased prevalence and incidence among women compared to men across the globe. So why is osteoarthritis, especially osteoarthritis of the knee, more common among women? Well, there are various genetic, metabolic, and biomechanical contributions, some of which reflect sex-based differences, but the exact cause of sex and gender-based differences in osteoarthritis remains unclear and really requires elucidation before it can inform clinical practice, whether we're talking about prevention efforts or treatment so we can improve patient care. Some of the issues noted in the literature describe issues with injury and response to injury, as well as inherent sex-based differences and it's issues such as inflammatory responses. So for example, women are more likely than men to sustain knee injuries, especially anterior cruciate ligament injuries. These are, and we know that if we follow people who have had anterior cruciate ligament injuries, there's a significantly higher risk of developing osteoarthritis at a younger age. And this is true for both women and men, but if you look at the graph on the right, you'll see that women are not only more likely than men to develop osteoarthritis after an ACL injury, but they also do it at a younger age. But we don't know why. Is there a difference in the degree of articular cartilage damage at the time of the initial injury? Are there sex-based differences in the inflammatory response to the injury? We're not sure why that occurs. And there's been more recent data that again confirms that women are more likely than men to develop osteoarthritis after an anterior cruciate ligament injury. And with the continued increasing number of women participating in competitive sports, this is an injury that is not insignificant in incidence. There are also various sex-based differences in lower extremity alignment and anatomic measurements and slopes around the knee that have been identified that could alter forces around the knee that could impact the development of osteoarthritis. In addition, there have been sex-based differences in gait patterns and forces and moments around the knee that have been identified, both those with and those without osteoarthritis. Most studies would indicate that these lead to increased medial compartment loading among women. So although this may increase the loading of the articular cartilage in women, how does this influence the development of osteoarthritis? And if so, are there prevention or intervention measures that we can institute? From a somewhat different anatomic perspective, Secotini et al. Reported that among people with normal knees, or so without osteoarthritis, and looking at MRIs, men have significantly larger knee cartilage volumes compared to women, even after correcting for body and bone size. So perhaps men develop osteoarthritis with a lower prevalence because they have more articular cartilage to begin with. So perhaps it takes a longer amount of time or maybe more significant injuries to damage the cartilage enough that men develop symptomatic osteoarthritis. Whenever we're looking at sex-based differences, obviously one area to look at is the impact of sex hormones. We know that there are estrogen receptors on chondrocytes or cartilage cells. We know that estrogen does have an impact on cartilage metabolism. It's just not clear and not consistently clear what that impact on articular cartilage is, and then how this could potentially lead to development of osteoarthritis at some point. In this study, there was a mouse model using an induced model of osteoarthritis of the knee. Among those mice that then underwent ovariectomy, there was a more rapid progression of the initial cartilage injury. This seemed to be lessened somewhat if the mice were then given supplementary estrogen. So there is some indication that loss of estrogen may help enhance or make more rapid, lead to more rapid cartilage loss. We really need to understand this better because we do know as women get older, they're more likely to develop osteoarthritis, and this is especially true after menopause. So what is the impact of estrogen on this? And can we come up with a clearer model of the impact of sex hormones on cartilage? There was a more recent study by Jin et al. That looked at men and women with osteoarthritis. Again, looking at using MRIs to look at cartilage volume. And in this study, they found that cartilage volume among men had no relationship to sex hormone levels, yet among women, cartilage volume was positively associated with serum progesterone levels, and that decreased levels of serum estradiol led to more changes in the adjacent bone. So again, indicating that there may be an impact of sex hormones, but we really need a clear idea of what that is, and is there any sort of intervention or anything that we can do with this data? We know that quadriceps strength is important to limit loading of the knee. So the stronger the muscle, the less impact there is on articular cartilage. Quad strength is also required to maintain mobility. So what is the potential impact of loss of quadriceps strength on the development or progression of osteoarthritis in women? In this study, quadriceps strength was assessed in a series of women who either did or did not have osteoarthritis. The presence of osteoarthritis was determined based on x-rays, not on symptoms. As you see on the graph on the right, the higher the grade of osteoarthritis based on plain film, the lower the level of quadriceps strength. However, it's important to recognize in this study that only about half of these patients had pain. So any demonstrated decrease in quadriceps strength was likely not because patients hurt, but was an underlying decrease in strength. There was another study recently by Thomas et al. That found more central quadriceps activation failure in women with a grade 1 level of osteoarthritis, or what's called doubtful osteoarthritis, so they're really not even symptomatic necessarily at that point. So this may indicate that quadriceps strength loss occurs first and may have some influence on the development of osteoarthritis. But this is something about which we need additional research. What does come first, osteoarthritis leading to weakness or vice versa? And it's important to recognize this because there may be some options for intervention or prevention of progression of osteoarthritis. We really need longitudinal follow-up studies of the loss of strength on the progression of radiographic and clinical osteoarthritis in women, as well as the potential impact on strengthening interventions, and again, focusing on women. What is the impact or response to obesity? We know that obesity can lead to an increased risk of developing osteoarthritis, especially around the knee, and the impact of the impact of obesity on the risk of developing osteoarthritis seems to differ between the sexes. In this study, women were more likely to demonstrate an association than were men between metabolic syndrome and symptomatic osteoarthritis. The effect of obesity was greater in women than men as you develop more severe levels of osteoarthritis. So if you look at the graph on the far right, you see the line at the top are obese females. And so the prevalence of osteoarthritis increased significantly as obese females became older, and much more significantly so than did men. However, although they're part of this is because of increased weight leading to increased pressure on articular cartilage, there's also has to be something else at play, because if you look at the risk of osteoarthritis of the hand among obese patients, especially women, there's also more OA of the hand. And this was demonstrated in this as well as other studies. And so if the impact of obesity is only because there's more weight that's putting pressure on cartilage in the lower extremity, why is there increased OA risk in the hand? And so again, it's probably more than just weight. There is probably some impact from a low-grade inflammatory response among patients with obesity. This may be mediated by leptin, potentially again leading to low-grade chronic inflammation. We know that women have greater inflammatory responses for other conditions. So is this association between obesity and inflammation and arthritis more significant among women than among men? We don't know, but something that needs to be looked at. There are also other inflammatory changes that we see related to osteoarthritis. Lee et al. Reported that cartilage among women with OA had a more robust inflammatory response than did the cartilage from men with osteoarthritis. Could this potentially explain why women, at least some women, have more rapid progression of their osteoarthritis than do men? These studies looking at osteoarthritis are primarily looking at impact on pain. We know that there are both sex and gender-based influences on the perception and expression of pain. So how much of what we are seeing is based not only on the damage that occurs at the joint level, but how that pain is perceived, whether you're male or female, and then how it's expressed from a gender-based perspective. This leads to some challenges when you're assessing data for osteoarthritis and looking at differences between sexes and genders. And is it because the joint changes are different, or because the pain is different, or the pain experience is different? When we look at women and men in the year prior to having a joint replacement surgery, we see that women have more frequent episodes of care. They're more likely to receive opioids, non-opioids, injections, physical therapy, et cetera. But again, we don't know why. Is it because there are differences in the way pain is experienced? Is it because of the inflammatory changes? Women have a more rapid progression of their disease. Is it because of their not being empowered or not being willing to seek care that's more involved, such as joint arthroplasty? Or is it gender bias on the part of the healthcare community and women being less likely to be referred for arthroplasty? Once men and women undergo joint replacement surgery, both men and women improve. However, at every time point, women report more pain and worse function than do men. And we need to understand that if we're going to try to improve pain and function after surgery. If you look at patients with end-stage osteoarthritis that are waiting for their knee or their hip replacement surgery, women have significantly lower health-related quality of life scores, self-efficacy scores, and lower levels of function. And so when you accommodate for these in assessments of postoperative pain and function scores, most of the gender-based differences go away. And so these preoperative issues may actually explain a lot of the issues that women have after surgery. And so again, why do they have more pain and worse function? Again, is it more rapid progression of disease? Is it gender biases in terms of referral for surgery? But they definitely come into surgery with worse function. But we really need to understand this better before we develop an intervention. At one point, there was an attempt to improve outcomes after knee replacement surgery by using what were called gender-specific implants. However, there's no indication that these implants lead to better outcomes than do standard knee replacement implants. And this just underscores that we really need to understand why women and men are different after joint replacement surgery before we start trying to find ways to change that. Another issue that may face women, however, after joint replacement surgery are issues with metal hypersensitivity. In this study, they were looking about the men and women who were referred with painful joint replacements. Women had higher levels of pain. Women also had higher rates and severity of metal sensitization. So that may be part of the issue in addition to their pain and function prior to surgery. So why are we concerned about osteoarthritis as a chronic condition among women? Osteoarthritis can lead to chronic pain. It can lead to difficulties with activities of daily living. If we look at the graph on the left, in terms of self-reported limitations in activities, women are more likely than men to attribute those limitations to having arthritis. On the right, among those people with self-reported arthritis, women represent the majority of those who note limitations in activities of daily living and lost days from work. And a study by Kotlars published in 2010 noted that women were significantly more likely than men to need time off of work because of their arthritis. There's also significant interaction of osteoarthritis with other health conditions, as you can see on the graph on the right. If you have obesity, diabetes, or heart disease, you're more likely than not to also have osteoarthritis. But it's more than that. If you look at other comorbidities, hypertension, depression, and COPD are the most common comorbidities for women and men with osteoarthritis, but the prevalence of each of these additional conditions is more common among women than men, and women also have higher number of comorbidities. The question, as you can see from the picture on the left, is there crosstalk among these various conditions and osteoarthritis, and are there common etiologies such as hormonal changes or inflammation? We also know that osteoarthritis of the knee can also lead to increased mortality, especially among women. This is primarily among women with knee pain, not just radiographic changes. This is primarily due to increase in cardiovascular disease. Interestingly, no similar increase in mortality among those with hand OA. So this may represent not only inflammatory changes, but also differences in mobility. And just a study here that we did that showed that when we looked at studies looking at OA of the knee, only about 30% reported differences based on sex. So again, emphasizing what was discussed earlier, that we needed to be much better about reporting results based on sex. So future directions, we need to better understand the impact of sex and gender on osteoarthritis in terms of risk factors, which can lead ideally to prevention. We need to understand better sex and gender-based differences in response to treatment and impacts on function, comorbidities, and mortality. This requires disaggregation of data based on sex and gender so that we can better inform clinical care, health professionals' education, and future lines of research. We also need targeted research and funding for OA risk factors in response to treatment, specifically among women, given what we're learning about differences in etiology and outcomes, especially given the interplay between OA, function, and other health conditions and related mortality. There are significant consequences if we don't specifically think about women and OA when designing studies and funding opportunities. And this includes addressing disparities in care for women who are underrepresented minorities, those living in rural and underserved communities, and transgender patients. And for all health conditions, we need better health education in sex and gender to train the next generation of clinicians and researchers. So thank you.
Thank you, Dr. Templeton.